Wonderful, and thank you for that very kind introduction. Um, on the next slide, just to mention, neither Kara nor I have any conflicts of interest or financial disclosures to report. And next slide, the next, I guess, 60 to 75 minutes or so, we'd really like to talk with you about some of the core activities around COVID prevention and response in nursing homes, and really go into a little bit about testing and cohorting. And so as I start and talk through the first few parts of this discussion, please bring your questions around those topics to us. Next slide. Throughout the presentation, we'll try to incorporate links to key CDC websites so that you have them as resources. I'm sure many of you already have them bookmarked or as shortcuts on your computers, because I recognize that we do change and update our guidance as we continue to learn with you about how best to address this frightening virus in our long-term care settings. And so we will always try to disseminate through our partners like IHI and Project ECHO when updates occur. And I find that I regularly benefit from checking in with these sites to see if there's been any new changes. Next slide. But the core activities that are recommended and that we have really seen highlighted by this pandemic are all about infrastructure for your infection prevention program, starting with the incredible importance of having individuals with dedicated training and time that can really focus on implementation of your infection prevention practices and your response activities, including education for everyone in the facility, staff, residents, and families. All of you are involved with the reporting into the National Healthcare Safety Network, which is a national infection surveillance infrastructure that we hope will not only support our understanding of COVID and its impact in the setting, but also be a resource for other infection tracking in your centers. And I know that for the last several months, you have been actively engaged in education and communication with your staff and residents and visitors about steps you're taking to address COVID, to keep it out through screening and restrictions to visitation, implementation of source control measures, and as we'll get into, implementation of testing and management of symptomatic residents and staff. Next slide. A lot of the core activities around implementation of infection prevention are not new. Making sure that we have infrastructure in our centers to support hand hygiene practices through use of sanitizer dispensers that are posted in places around the resident care activities that make building hand hygiene very accessible into the workflow of our staff. And similarly, ensuring that the appropriate products for cleaning and disinfection of shared equipment and surfaces are also well accessible to individuals at the time that they're needed. I know that personal protective equipment and managing your inventory has been a major challenge and concern, and we'll touch on a few of the issues that we've seen centers struggle with when it comes to balancing conservation of equipment with safety. And COVID has really also brought to the forefront the importance of respiratory protection programs and in the use of N95 respirators as part of our complement of personal protective equipment. Next slide. So let's talk through some of the basics about SARS-CoV-2 testing and some considerations about how to use these how to use these tests. This first figure is a little bit complicated, so I'm just going to highlight a few things, starting with at the very left of the figure. You see that there is a window of time as large as 2 weeks where an individual may be infected and incubating SARS-CoV-2 virus without having any symptoms and without having detectable virus or any tests that would recognize that infection is present. And that is a really important point that we'll return to when we talk about quarantine and some of our cohorting considerations. But just following one of the lines, the blue line, shows that around 2 days prior to the onset of symptoms, you start to see the viral detection through diagnostic tests like PCR. And this is likely comparable with antigen testing, starts to peak and is high for the first week or so. And this is when active infection is recognized, and we can use these viral diagnostic tests. Over time, though, you start to see those viral levels declining as the body's immune system starts to respond and develops, generates antibodies to the virus. And at this point, you may not see as readily the virus present as your immune response is controlling and containing the virus. And so there's a window where the antibody will be detectable and remain after the virus is no longer present and recognized. Next slide. So with that in mind, this table sort of highlights some of the different diagnostic tests available for SARS-CoV-2 and really want to make the point that in the green box, the molecular and antigen viral diagnostic tests are the primary tests used to determine presence of active infection. And by the time you start to see serology testing turn positive or antibodies detected, that is more an accurate reflection that infection has happened in the past. So we use it for surveillance often to see across the population how many people may have had COVID at one point, but it is not a good test to look for active clinical infection. And because we are still learning about the protective effects of immune response with SARS-CoV-2, at this point, we do not exempt residents or staff from facility-wide viral testing because of positive serology. Next slide. This table highlights some of the differences between the viral diagnostic tests, the molecular tests like polymerase chain reaction or PCR, which is really looking for the genetic material of the virus, and the antigen test, which is looking for proteins that are present on the surface of the SARS-CoV-2 virus. And here I've highlighted the difference in sensitivity and specificity between these two tests, because I think you'll hear a lot about that in the discussion of how to use these tests and where there are differences in interpreting results. And as a reminder, when we talk about sensitivity, which is really the issue that we worry about with the antigen test, it is how accurate can this test detect positive patients with infection. And so is a positive test found consistently when we use it with someone who has an infection. When you have lower sensitivity, you worry about false negative results, meaning I have infection, but the test looks negative. On the other side is specificity, which is how accurately you get a negative test for an individual without infection. And so those two characteristics, which are really innate characteristics of the test, sort of balance between between them. And sometimes as you increase sensitivity, you might lose some specificity and vice versa. Next slide. But I also want to mention there are other factors that play into our detection of virus and the way we interpret results, starting with the quality of specimen collection. If we have inadequate sampling, the time that the swabs are taken, or there's some mishandling of their storage prior to being put on the testing platform, that can result in false negatives, for example, and failure to recognize virus even though it's present. I know a lot of centers are receiving and will continue to be receiving testing platforms, primarily the antigen rapid point of care tests. And so as you start to use these tests, it's really important that the individuals who are responsible for using the test have training, feel comfortable with the sample handling as well as the use of the test, and that they build the use of quality controls into their process whenever they have a new batch, for example, of test kits. Using those quality controls ensure that the testing platform is working as it should. The timing for testing, as we talked about in the previous slide, is part of what we have to account for when we use these tests, and recognize that somebody who may have a very recent exposure, who has not had enough time to incubate and start to have virus detectable, may in fact have a negative test despite the fact that they are infected. And finally, the performance of these tests are also affected by the prevalence of COVID in the center and in the community. So when we see a lot of testing done in areas with low prevalence of COVID, meaning there's not very much virus around, but we're using the test quite a bit, that's a circumstance where we might see some false positives. So we have to think about how we deploy these tests in the context of our community. Next slide. So another set of terms that you might hear about are sort of diagnostic testing strategies versus screening. And primarily, the distinction here is that when you use diagnostic testing, it's used when you are concerned about someone with active symptoms and you're trying to diagnose COVID infection. It's used in the context of outbreaks as well. And in that sense, you may be testing people who don't have symptoms, but because there's virus present and there's been a recent exposure to someone who is infected, we use diagnostic testing to try to detect people who may be asymptomatically infected or pre-symptomatically infected, meaning they are in those early stages of incubating virus but haven't quite started to manifest illness. Screening strategies are used to intermittently look for individuals who may be harboring infection and are asymptomatically infected without an awareness of a known exposure. So these are strategies that are being looked at for work places and also in nursing homes and schools. And so we do screening to try to identify individuals who may be infected and a source of spread, to implement measures to stop further transmission of the virus. Next slide. But the primary way that we are going to talk about testing in our recommendations are largely focused for residents around investigation of an outbreak, and that is defined as a new SARS-CoV-2 infection in either healthcare personnel or staff person, or when you have a new facility onset infection in a resident. So someone who has been in the center for some time and starts to develop new symptoms and an infection is diagnosed. in that circumstance, we will recommend expanding diagnostic testing for all residents and staff in the center, prioritizing those with symptoms, but trying to also more broadly look for those asymptomatic infected individuals, because we can then deploy infection prevention practices to address those. Sometimes supplies and capacity of our laboratory testing can restrict how broadly we can test. And so we do understand and recommend sort of, again, unit-based or prioritizing high-risk individuals if you don't have adequate testing supplies. And after that initial look for following an exposure, we continue to recommend testing every few days until you don't see any new virus infected individuals detected. And the reason that we recommend this to continue for at least 14 days is because, remember, there was that 14-day window from an initial exposure to when you might start to have clinical illness. And so we want to ensure that we're looking carefully for newly infected individuals that could have had that initial exposure as far back as 10 to 14 days ago, and we don't want to miss them. And again, if we have capacity limitations, then we prioritize how we use those tests as well. Next slide. And this data slide is really illustrating why we promote the facility-wide testing when there's a new detection of a case. What you're looking at is data from about 90 nursing homes that were working across 5 different health jurisdictions. They were doing broad COVID testing in response to a case when it was introduced, and the median time from the detection of that first case to implementing the facility-wide testing was about 7 days, but there was a fairly large range from 1 to 41 days. And what this is showing is that the sooner you are able to implement facility-wide testing in association with a new case, the fewer new additional cases are occurring. So for every added day that it took to implement that facility-wide testing, there was another 1.3 additional cases identified. So it really emphasizes the faster we can deploy these testing strategies, the better we can contain spread. And these on this last slide are just some of our testing websites. And I'm going to stop with those and open it up for some questions. Thank you.
Excellent. Thank you so much. We can start on the next slide. Thank you. So cohorting, or the practice of grouping together residents with similar infectious processes, can be very beneficial to help manage an outbreak of COVID-19, but it does have the potential to become very complicated and very quickly when trying to create categories and move residents around the facility. The approach to cohorting may not necessarily be the same for every facility. So I wanted to spend some time, hold on one moment as I make my slides a little bit more. Give me just one moment.
Dr. Slivka, could you move your microphone closer to your mic, to your mouth, sorry? Yeah.
Can you hear me okay?
Better now, yeah, please.
Perfect. Okay, sorry, Sorry about that. The Zoom call keeps minimizing on me. And I wanted to make sure I can make sure that the screen is on the correct slide, but we are now. So what I was starting to say is that the approach to cohorting for each facility may not necessarily be the same, but what I wanted to talk with you all about are some of the key cohorting strategies that you can use to help make important decisions when you do have COVID in the facility. The goal of cohorting is to minimize the risk of exposure and prevent additional spread of SARS-CoV-2. So on this slide, you see some of the various COVID categories that a resident might fit into over the course of their care in a facility. The red, green, and yellow categories are groups that we have commonly seen facilities use for cohorting, but it's important to note that other than that COVID confirmed cohort or that red group, the status of residents in all of those other cohorts is not certain. And even that negative group, or as we prefer to call it, the unknown category, that status can change at any point in time. And the need to monitor residents for signs and symptoms of COVID, to practice universal source control, social distancing, and the ability to implement additional precautions still exists in all of those other categories, even outside of that COVID confirmed group. So one of the things that we have observed are facilities trying to create cohorts based on exposure status and based on symptoms. And so I want to describe a bit more to you all why this can be really difficult and sometimes may actually be problematic. Next slide, please. The challenge with defining a cohort based on exposure is that the extent of exposures and the risk of developing infection can vary significantly for residents. And we may not be able to fully understand the potential exposures. So, for example, residents who have had direct exposure to known COVID-19 cases, such as a roommate of a resident who's found to have COVID-19, they have a higher risk of infection, but it doesn't necessarily mean that they will definitively go on to develop infection. And on the other hand, there's an exposure risk among newly admitted or readmitted residents, as well as those who need to leave the facility regularly, such as for outpatient hemodialysis. But that exposure may differ even within that category. And that may differ depending on where you're at in the country and what your prevalence of COVID is, as well as how well IPC practices are followed, and things like the transportation process and getting to and from an out of the facility appointment like dialysis. So you may not be able to tell whether close contacts have occurred or how high that risk of infection is. And by cohorting or combining all of these exposed residents together, you could actually increase the risk of exposure for some of these residents and increase your risk of transmission. Similarly, cohorting residents based on symptoms is not recommended because symptoms just with COVID are not a reliable way to detect the infection. We discovered early on during this outbreak that as many as 30% of residents with symptoms consistent with COVID-19 tested negative. And we've seen pre-symptomatic and asymptomatic residents with COVID-19 infection serve as a source of spread to others, despite having minimal to no symptoms. So cohorting based on symptoms could inadvertently expose additional residents as well. Next slide, please. With the primary goal to prevent exposures and transmission of SARS-CoV-2, our recommendation is that you prioritize the confirmed COVID-19 cohort and creating a separate area in your facility for COVID-19 care. This could be a floor of your facility, a unit, a wing, even a group of rooms at the end of the hall. But ideally, you find a way to physically separate that area from other rooms or units. And then even more ideal would be to have a completely separate entrance to those units. Healthcare personnel working on the unit should practice social distancing and should have access to a restroom, a break room, and work areas that allow them to continue to remain separated from healthcare personnel working in other areas of the building. We do recommend trying to establish this space before you have cases in your building, but even if you already have identified cases, unless the majority of your residents are infected, you should still work to create a dedicated COVID-19 unit. Make sure also in this unit that you have an area for a clean area for donning PPE, a space for doffing PPE, and decontamination of eye protection, as well as performing hand hygiene. We do recommend, as mentioned during the question and answer section, that you assign dedicated healthcare personnel to work only on the COVID-19 care unit. At a minimum, we're talking about the nursing assistants and nurses assigned to care for these residents. And again, with the goal being to prevent transmission of SARS-CoV-2, we want to avoid the same staff person going back and forth between caring for a resident who has COVID-19 and a resident not known to have COVID-19. We know also that this can be challenging for some facilities, especially when that number of residents with confirmed COVID-19 is small. So one suggestion would be to consider at least dedicating healthcare personnel for entire shifts if they aren't able to be dedicated for longer periods of time. And then additionally, finding ways to support and recognize your staff can also help with staffing this unit. Next slide, please. You can empower your staff by ensuring that they have training on how to use PPE in a way that can help keep them safe and help keep their residents safe. And an important thing that I wanted to talk about specifically is that with PPE shortages, the strategies for using PPE currently have differed from how staff have used PPE in the past. And this may continue to change for your facility over time. So it's important to continue that education process. And it's also really important to evaluate how you're using PPE. Specifically, when we talk about some of the optimization strategies, when you're using crisis PPE strategies, it's really important to make sure you're evaluating to see if you can move back into contingency or conventional optimization strategies as soon as you're safely able to do so. And another thing to consider for this unit is the medical care that will need to be provided. And we encourage you to think about the needs that your ill residents may have, because unfortunately we have seen that nursing home residents can develop very serious infection with COVID-19, and they can do so relatively quickly. So they may benefit from increased access to clinical providers, whether it's on site or through telehealth, as well as having supplies like oxygen supplies and dedicated equipment for those residents and for whatever support they may end up needing. Next slide. So not every facility will have the ability to create an observation unit for monitoring residents. What CDC has recommended is that depending on the prevalence of COVID-19 in the community, you place newly admitted or readmitted residents in single-person rooms or an observation unit for 14 days after their admission to monitor them for signs and symptoms of COVID-19. And as I described earlier, you want to avoid placing residents with different types of exposures and risks into shared rooms. Some of these residents are going to have had recent COVID testing. However, we consider them to have an unknown status, even if they've tested negative, because they may have had an exposure at any point up until their admission to the nursing home, and they may go on to develop infection with or without symptoms during that 14-day incubation period. So they should be cared for using all recommended PPE and transmission-based precautions during their care. And I'm going to touch back on these optimization strategies for PPE. One of those strategies is the extended use of gowns. However, even though this may be used in some crisis settings, specifically on dedicated COVID units, it's not a practice that we recommend for other cohort areas, such as an observation area, because these residents have not been confirmed to have the same infectious pathogen. And so you don't want to be extending the use of your gown or wearing that same gown in between different residents because of the concern that that could contribute to transmission. And then last, testing at the end of those 14 days is something that can be considered, but Testing upon admission to the nursing home or testing at some point within that quarantine period should not be used to discontinue those precautions early. Next slide. One way to start the planning process for your facility is to take a look at a map of your facility. In this example, the facility was able to dedicate a specific wing of the facility for COVID positive individuals, which they were able to separate from the rest of the facility. And they actually had a small wing that they were able to dedicate to an observation area as well. That was separate from the main facility where the asymptomatic or presumed COVID negative residents resided, but also separate from the COVID positive area. But again, the priority is to create a space that's for residents with confirmed COVID-19. Next slide, please. I wanted to share with you a few excellent examples that we have seen of ways in which nursing homes around the country have created COVID-19 care areas. So in this first picture, you see that they have hung a temporary clear barrier to separate the COVID unit from the rest of the facility. And the feedback was that this has helped reinforce the separation of that COVID unit for not only staff, but residents as well, and reminding staff to be aware of their PPE and prevent both staff and residents from accidentally moving between units. In the second picture, the facility actually built a temporary wall, which you can see at the back of this picture to the left, to completely separate the area for COVID unit staff to enter and exit into that unit. And then in this third picture, you can see how a facility hung curtains and spaced out residents in a therapy area in order to allow those residents to continue to receive the care that they need in as safe a manner as possible. Next slide, please. So a couple of key points that I wanted to leave you with before we move on to additional questions. I want to highlight the importance of continuing to remain vigilant in your efforts to prevent COVID-19 from entering or re-entering your facility, especially in the future as you may begin to move towards easing some of the restrictions that you have in place. Identify infections early in order to prevent the spread of SARS-CoV-2 by continuing to screen healthcare personnel, to screen any visitors that are allowed into your facility, as well as residents. And stay on top of your PPE supply, planning for the future, and assessing the strategies and practices that you're currently using. Create a designated space for COVID-19 care, including thinking about how you can dedicate healthcare personnel to work on that unit, keeping in mind that a unit like this may possibly be useful for other infections as well as we begin to get into respiratory virus season. And have a plan for the testing that you will do or that you may need to do, as Nimali was discussing earlier, for residents and healthcare personnel. And then I also want to add in the importance of making sure that you are reporting COVID cases, and lastly, make sure that when you think about ways that your facility is considering cohorting residents, that you are prioritizing that COVID unit, but that you are thinking about when you are moving residents who are not confirmed to have COVID-19 into similar or shared areas, that you are thinking about and assessing the reason for being on that unit, whether they are new admissions or readmissions, whether they have had exposures, and what level of risk they may have had, so that you aren't inadvertently increasing their potential to be exposed to COVID-19. Next slide, please. And last, I wanted to make sure that we shared, we've recently updated the landing page for our nursing home website. The page now goes to a summary or a collection of the variety of different resources that we have available. You can easily link to our infection control guidance specific for nursing homes, as well as our testing guidance, an infection control assessment form that we have, as well as a variety of training materials and other resources that you may find helpful. Next slide, please. And with that, I want to thank you for listening to information about cohorting and open up for questions.